Good afternoon, ladies and gentlemen. My name is Tiantian. I'm from Anshan People's Hospital. I'd like to share a case with you today. The title of my speech is "The Culling Fox is no match for the good hunter." I will elaborate on the following 4 aspects. First, let's take a look at the medical history. 45-year-old female patient, purple mass of right breast. There was no obvious uplift or depression, local tenderness. 2-dimensional ultrasound. A mixed echo was detected in the right breast at 9 o'clock. The shape was irregular. The margin was fuzzy. The internal echo was uneven without calcification. It grew parallel to the skin, and the posterior echo did not change. Just like a hunter met a fox and found a lamb in its belly. Round 1. The hunter took out the first weapon, color Doppler ultrasound. No obvious blood flow signal was found in the mass. Ipsilateral axillary lymph node enlargement, cortical thickening, lymphatic highly structure shift. Round 2. The hunter took out the second weapon, shell wave elastic ultrasound. The blue block was basically covered. The shell wave velocity was 29.5 kPa. Round 3. The hunter took out the third weapon, automatic breast volume scanner. In coronal view, there was no obvious retraction phenomenon. The burst sign could be seen around the mass. Round 4. The hunter took out the fourth weapon, contrast-enhanced ultrasound. The 4 ml Sonovil contrast agent was injected by bonus. The lesion showed enhancement at 10 seconds and peaked at 15 seconds. The lesion appeared a high enhancement of heterogeneity, and the contrast agent washed out at 29 seconds. The enhanced mode is fast in and fast out. After contrast-enhanced ultrasound, the mass area was slightly enlarged. The time intensity curve shows a sharp rise and a slow decrease. Through the above all examinations, I think everyone has a preliminary judgment. I think you may be the same as me. With the deepening of the examinations, we have been upgrading the mass. We did a biopsy of the mass. The pathological result is malignant tumor combined with immunohistochemical results, considering invasive carcinoma of no spatial type with partial invasive micropapillary carcinoma. Then the patient underwent surgery. The surgical pathology is invasive micropapillary carcinoma of breast 70%, with invasive carcinoma of no spatial type 30%. Was found in the modified radical specimen of right breast. No nerve invasion vessel could be seen. Axillary lymph nodes were positive 8/21. Cut open the belly of the fox. The hunter found a lovely chick. At last, the chick was saved. Next, let's talk about the definition of disease. IMPC is an invasive carcinoma in which tumor cells are arranged in small clusters in the interstitial fissures similar to vessels. The morphology of IMPC is similar to that of papillary intraductal carcinoma. Most of them occur in 46 to 65-year-old women, accounting for 3% to 6% of breast cancer. Most of the cancer cells are moderately and poorly differentiated. IMPC can occur alone or in combination with other histological types of breast cancer. Most doctors think that when the content of papillary carcinoma in tumor tissue is more than 50%, it is recommended to be the standard for diagnosis of IMPC. Next, let's look at the different features between IMPC and IDC. The infiltrating direction of IMPC goes laterally along the blood vessel. The infiltration direction of IDC can extend along the tissue gap in all directions, and the aspect ratio increases. IMPC lacks of fibrovascular axis coordination. IDC secretes tumor angiogenesis factor. IMPC mostly has micropapillary structures, and IDC has large amount of collagen tissues. The tumor-like cell of IMPC infiltrates into the periphery of the lesion at a relatively uniform rate, showing an expansive growth. The age of IDC shows crabfoot-like changes. IMPC has a biological structure of polarity inversion, so it has higher lymph node invasion rate and metastasis rate than IDC. It's the pathological characteristics of IMPC different from IDC that lead to atypical manifestations in different ultrasound modes. In summary, IMPC is a kind of breast tumor with special pathomorphological characteristics, and its two-dimensional ultrasound performance doesn't have typical characteristics of malignant tumor. The application of multimodal is helpful to improve the diagnosis rate of IMPC, and contrast-enhanced ultrasound plays a very important role in this examination. As our title says, the cunning fox is no match for the good hunter. That's all. Thank you.
Thank you, Dr.任恬恬, for your presentation. Now we would like to have Dr. Qin Jiale to comment on the case and ask questions.
Thank you for your presentation. It's a very special case of breast cancer. And I'm very glad you read lots of paper when you met a confused case in your clinical work. It's very great. And so my question is, when you met a similar case again, what will you do in your clinical work? You use several ultrasound technician to test this breast cancer. What kind of technician will you use first, and what do you think?
Thank you for your good question. At the beginning, when I saw the case, I just category 3. But when I find the ipsilateral axillary lymph node enlargement and the thickling shift, I'm very puzzled. So I use the shell wave elastic ultrasound, but it's so soft. But I'm also puzzled, so I use the automatic breast volume scanner. I found a little birth sign could be seen around the mass. So we decided to take a biological. So we did the contrast enhanced ultrasound. We just find where the the agent was filled, but after the contrast agent, we use the parameter. We found the sharp rise and slow down the TIP. So we upgrading the mass. Thank you.
Thank you for your answer.